Good morning everyone. Let's deal with the anterior shoulder instability in today's lecture. We have already seen in the last lecture that anterior shoulder instability is very common and it is seen definitely in 90% more commonly compared to the other direction shoulder instability. The cause is either due to traumatic dislocation or repetitive microtrauma leading to symptomatic episodes of subluxation, that is painful range of motion during subluxation, clicking sound as well. Usually post dislocation, the arm position, I have already explained why it is maintained in abduction and external rotation. Physical examination which is seen in the patient is usually the arm is held in abduction and external rotation. Palpable fullness due to the dislocation in the anterior shoulder region. Internal rotation and adduction may be limited. Evaluation of neurological injuries before relocation maneuver is very important because the axillary nerve and the axillary artery pass nearby to the anterior region of the shoulder. Thus, whenever you are suspecting a patient to have anterior shoulder instability, do assess for axillary nerve and axillary artery. Axillary nerve is commonly injured with the anterior dislocation. Coming down to the traumatic shoulder series is a definite whenever you are doing any direction shoulder instability. Patient characteristics usually within 30 years. Average percentage is 50 to 70% of recurrent dislocation if treated non-surgically. Non-operative rehabilitation. Phase 1 will just deal with phase 1, 0 to 2 week. That is half a month, 15 days, 14 to 15 days. Restriction. Avoid provocative movement that risks the shoulder like external rotation more, abduction more and distraction. These all are going to dislocate the shoulder. This is for anterior shoulder instability. It is not for any other direction. Immobilization is a must in sling. Remove the sling during exercise. Duration of immobilization varies with the age. If the patient is below 20 years, 3 to 4 weeks of immobilization. 20 to 30 years, 2 to 3 weeks of immobilization. Greater than 30 years, 10 days to 2 weeks of immobilization. Greater than 40 years, definitely it is more, that is definitely it is less, that is 3 to 5 days. As the age increases, the number of days for immobilization decreases. That is what we saw in the in the immobilization phase. That is the reason behind this is due to as the age progresses, the chances of having frozen shoulder is more common. Thus, if you are maintaining after the instability, if you are maintaining immobilized that joint, it is definitely leading to the traumatic cause of the frozen shoulder, that is frozen shoulder type 2. Pain control. Reduction of pain and discomfort is a must either via medication or through your therapeutic modality. Medication, narcotics for 5 to 7 days is definitely prescribed. The patient first visits the orthopedician. If he just visits the physiotherapist for the first time at the injury itself, then give ice, ultrasound and high voltage pulse galvanic stimulation. Motion, passive progress to active, that is first start with the passive range of motion, then progress to active. In phase 1 you have to attain 0 to 130 degree of flexion. Pronation, supination of the forearm as tolerated. No other motion to be carried out in the phase 1. Muscle strengthening protocol. Scapular stabilizers strengthening is begun during phase 1 for a patient who is 30-year-old, and also grip strengthening is done. Coming down to phase 2, that is your 3 to 4 week. First one was 0 to 2 week. This is for 3 to 4 week. Criteria is reduced pain and tenderness, adequate immobilization. Restriction is avoid provocative movement that rests the shoulder joint as same as in phase 1. Restriction, shoulder motion here to be restricted for 140 degree of shoulder forward flexion, 40 degree of external rotation with arm at the side, not a 90 degree. Strictly avoid extension. Coming down to immobilization, use shoulder sling as given in the phase 1. Motion here. In phase 1, the motion was 0 to 130 degree flexion and pronation and supination. Here in motion, it is 140 degree flexion, 40 degree of external rotation with arm at the side. Exercises begin the Codman pendular exercises to promote early motion. Passive range of motion exercises is started, followed by active assisted, followed by active range of motion exercises. Muscle strengthening. Rotator cuff strengthening is very important. Begin with closed chain isometric strengthening with elbow to 90 degree at the arm at the side. Please maintain elbow at 90 degree flexion with the arm at the side. Now, what are the exercises to be performed in closed chain isometric strengthening for for the shoulder? That is for internal rotators, external rotators and flexors. No abductors again. Strengthening of scapular stabilizers, in which we are going to follow closed chain strengthening exercises, scapular retraction, scapular protraction, scapular depression, shoulder shrugs. Shoulder shrugs while performing, please maintain, you have to check that whether the trapezius is overactive. In such patients, do not perform shoulder shrugs again. Coming down to the phase 3, that is 4 to 8 weeks. Phase 3, that is 4 to 8 weeks. Criteria: pain-free range of motion for 140 degree of forward flexion and 40 degree of external rotation with arm at the side. This was the main goal in phase 2. So that should be a criteria to get the patient to phase 3. Minimal pain or tenderness with the strengthening exercise. Any strengthening exercise should cause only minimal pain. It should not cause more amount of pain. Improvement in strength of rotator cuff and scapular stabilizers is the major criteria for phase 3. Restriction in phase 3 is avoidance of the position that exacerbate the instability like abduction and axial rotation more. Shoulder motion should be only 160 degree in flexion, 40 degree in axial rotation with arm at 30 to 45 degree of abduction, not at the side as it was given in phase 2. Goals of motion should be forward flexion 160 degree, 40 degree of external rotation with arm at the 30 to 45 degree of abduction. Exercises should be passive range of motion, active assisted range of motion and active range of motion. Progression. Muscle strengthening should be closed chain isometric, but same thing in phase 2 it was arm at the side, but here it is 35 to 45 degree of abduction. Progress to open chain strengthening with TheraBand. Exercise performed with elbow to 90 degree like as it is seen in phase 2. TheraBand performs usually isotonic exercises for external rotation, internal rotation, abduction and flexion. Progress to isotonic dumbbell, which was not given in the phase 2. It was only TheraBand exercises. Here you can do dumbbell exercises as well for the same movement. Strengthening exercises for scapular stabilizers should be progressed from closed chain to open chain exercises. Initiate. Please make sure in phase 3 we are going to initiate deltoid strengthening. Very important. Initiate deltoid strengthening in the plane of scapula to 90 degree of elevation. Deltoid is very important to be strengthened because it is a multi-axial and bulkiest muscle, one of the bulkiest muscle of the shoulder complex. It has its activity in flexion, abduction as well as your extension. But make sure you are going to initiate the deltoid strengthening in the phase 3. Coming down to phase 4, that is 8 to 12 week. Criteria is pain-free motion should be attained for 160 degree of flexion and 40 degree of external rotation with arm at the side, abduction of 30 to 45 degree. Minimal pain and tenderness with strengthening exercise. Continued improvement in the strength of rotator cuff and satisfactory physical examination. Goals of phase 4 are improve shoulder strength, power and endurance. Also improve neuromuscular control and shoulder proprioception. Restore full range of motion. Restriction: avoid exacerbation of the instability. Pain control same as phase 3. Motion: obtain motion that is at least equal to the contralateral side. At least, not completely equal, at least nearby. Exercises: passive progress to active, assisted progress to active range of motion. Capsular stretching, especially posterior capsule. Why we need to stretch the posterior capsule is because in anterior instability the head has moved forward. The trauma is on the posterior capsule. The main thing why I am explaining is this is under the term capsular obligate translation. Anything happening to the capsule in posterior or anterior direction, the head of the humerus moves opposite side. This all is happening due to capsular obligate translation. So in our case, we are dealing with anterior shoulder instability. The head of the humerus is moved anteriorly. Thus, where is the trauma to the capsule? Posteriorly. Thus, you need to stretch the posterior part of the capsule. In which phase? Phase 4. Very important in phase 4. Muscle strengthening in phase 4 is continued rotator cuff strengthening, scapular stabilizers and deltoid strengthening for 8 to 12 reps for 3 sets. Upper extremity endurance training is definitely done by your upper body ergometer and PNF pattern. The last phase is your phase 5, that is for 12 to 16 weeks. Criteria to enter in phase 5 is pain-free range of motion, no evidence of recurrent instability, recovery of shoulder strength for about 70 to 80% of the contralateral side, satisfactory physical examination. Goals in phase 5 are prepare gradual return to functional and sporting activity, establish a home exercise program. Functional strengthening, plyometrics is definitely performed, and progressive systemic interval program for returning to sports, which is sport specific, that is golfers, overhead athletes like throwers and tennis. The last part of the rehab protocol for shoulder instability in anterior direction is maximum improvement is noted by 6 months. The 6 months is very important. Warning signs: persistent instability, loss of motion, lack of strength and continued pain. Treatment is going to be move back to the earlier phase, may require increased utilization of pain control modalities, may require surgical intervention. Thank you one and all. Let's meet you all in the next video.